Good almost afternoon. I mean, I think everybody in this room knows me except for you.
I'm a newbie.
Okay, hi newbie. No, I know that's not your name. My name is Jerry. What brought this about was just the confusion that I've been seeing from people, and hearing from people in terms of what is going on in terms with healthcare, especially. And I thought, well, I need to go ahead and just give you a background, and I will show you what the mission of this conversation is going to be. In case you are wondering why I'm dressed like this, I was in Washington, D.C., Maryland, actually, just in the suburb of D.C. Yesterday, I've been gone since Thursday. We had a 58th high school reunion. We have this every year. So people flying from all over the whole place, from Canada and all over US. So, and it so happened that one of our classmates was celebrating her 70th birthday too. So we did the meeting side on Thursday, Friday, tried to visit my family in Maryland. And then on Saturday, there was a big party. We had a church service first, and then, we just drove from there to the event place, and they had a very big party. Whoever came here early, you got the opportunity of hearing the same kind of music that I was hearing last night. So I thought, well, at something that's different, I'll wear what I wore yesterday. There's a 3-piece. This is only 2 pieces. There's a bigger one that goes on top of this, but I don't want to overdo it.
Allow attention already.
Okay, thank you. Where's John? I want to thank John from the bottom of my heart, because the last time I was supposed to give this talk, I mixed the dates and I couldn't, give it. But in his good heart, he went back, rearranged things because of the importance of this topic, to make sure that I come back again to give it. I did call him before I went to Maryland. I said, don't worry about it. I'll be here. If I don't have to sleep all night just to sit, I will do it. But guess what? I will be here to give this speech today, and on time too. I arrived in church just as Pitt was dismissing everybody. So it was very good timing. I want to also thank my wife, Leah. Everybody knows Leah. The other Leah. You are pointing to her. Okay. I thought you are, going like this. Okay. So she has gone through this at least about 7 times. I have rated this about 18 times up till last night after I came back from the party, because something is just not good enough for me, So for whatever it is, this is what you're going to get now. If you would like a copy of this presentation, an electronic version, that way you can access all of the sources at the end that I have. I will send this to Peter, to John after this presentation when I get home. And then if you get in touch with John, he can send you a full copy of it. Okay. I have another copy at home that is more in depth. That's the one I'm going to send to John. That way, you'll get the full Monty. All right? Okay, good. My background. I went to school at Howard University in DC, and then I started grad school at Georgetown, but had to leave to go work. Eventually, I finished my graduate studies in engineering, and I did my MBA from University of Michigan.
Water.
So, do we have the mic? The mic.
Okay. Is this loud enough?
That's better.
Okay, but is it enough? Keep it up. I think if I keep it up there, I will be shouting.
Rick will set that up, but keep going.
Okay, all right, good. So, my background, I've been in healthcare for a very long time. I think my first managerial job was in 1986. From there, as a manager, as a director, senior director, administrator, vice president, chief operating officer / general manager, I have gone through all the gamut. Somebody was teasing me, why don't you want to be a CEO? I said, no, that is too much for me in terms of responsibilities. Most people don't realize what administrators in a hospital do. And I'll just give you a glimpse of that as I go along in this presentation. All right? Okay, next slide. So there's a connection between, faith and mission, because in healthcare, what we do is compassion. Most of the hospitals I've worked with are faith-based hospitals, but I've worked in all kinds. I've worked in, a city hospital, and I've worked in a hospital that is privately owned by a physician. But basically, what they do is to make sure that when people are sick, they look after them with compassion. That's why, at times when people have mental disorder and they come to the hospital, by the way, the number one place where people get abused on the job is working in the hospital. Because people spit on you, they hit some of the nurses, and you can't hit them back. No, you cannot. Otherwise, that becomes battery or assault. And also, you need to learn to do the right thing, seek justice, and defend the oppressed. In each hospital, they always have one person who is responsible if you get a bill and it's too high and you cannot afford it. I'm going to talk more about this later on. They have this individual that you can get in touch with. They'll find out how much your income is, how many people in your household. And at times, they can forgive all your bill. Most of the time, they may ask you to pay maybe, 5 cents on a dollar on your bill. Just something to make sure that this is not too much of a stress for you. And the last thing is to care for the vulnerable, because we have people who come to the hospital, especially to the ED, who are homeless or maybe are just living on the streets by choice. We still have to treat them. We cannot discriminate on who we take care of. Okay. We cannot discriminate in healthcare in terms of who we treat. And we have to treat everybody the same way we'll treat somebody who's homeless is the same way we are supposed to treat somebody who's the president or even the CEO of the hospital. Incidentally, twice I've treated CEOs of my own hospitals, in the oncology center, in the cancer center. And the same kind of privacy that we give everybody else is what we need to give to them. So the goal is how the government policies affect average congregants. By the way, I was talking to Chris, and the average age of people that go to the church here is about 65 on the average. We have people who are in their 90s. We have younger people who are in their 20s, but the 20s are the outlier.
That age again.
Okay. I said the average age in church is 64 to 65. So
You think it's
we have young people in their 20s, just like you or Daniel, and we have people in their 90s. But when you put everything together, that's about, the mode age, the mean age, for people in the church.
David, you think it's older?
Oh, how old I am.
So I'm going to go about healthcare policies, with the government, responsibility of the church leaders, government responsibility, responsibility of all of us that go to church here, and responsibility of the church leadership of this church. So, if you have any question along the way, please do what David did. Just ask me the question. I'll be more than glad to answer. Normally, if I have younger people, I'll tell them to wait till the end, like college students. But I don't want you to wait till the end. Otherwise, if you're like me, I'll forget the question. So ask the question as we go along. One thing that I did, you see this area here? Okay. You see this rectangle here? When you look at the population there compared to New York here, by the way, this is a map of people over the age of 65. You see that most of them are in Florida and California. But if you look at the mixed US, which we'll use as the empirically, the mode, and you compare it with New York, 15.7% of all of, these people here, 55.7% of New York compared to these people. So you see that we have a lot of mature citizens in New York. At times, people think everybody goes down to Florida or to Arizona or North Carolina, but I find that not to be true in New York City. Most people, they may go there during winter, but they are back here, and their home is here, and they vote here. So yes, ma'am.
Think about when you cover the snowbird situation, so older person will physically locate at two locations.
That is correct. But most of those people, they still have their houses here.
Right.
And they vote here also.
Right. But if they go to somewhere else, they still need health care. Right. And that coordination is a big problem.
Yes. Yes, that is correct. An issue that I'm not going to mention here, but there was a time when they were trying to have a national directory. It's still here, but most people don't want to put their information there for fear that somebody may hack in Florida and get the information from Michigan, or somebody may hack from Arizona and get the information from New York. So most people are not using it. That's why I just wanted to put that one on the side. But if you want more information about that, I can always give another talk about that, the law that governs it and how it operates. Thank you. Can you hear the speaker now?
Yeah.
David, good for you? Okay, thank you. So, like I said before, healthcare, usually it comes from the national level, vis-a-vis CMS, that's Center for Medicare and Medicaid Services in DC. Does anybody, apart from you, John, does anybody know who the secretary is?
Did you change recently?
I need a name.
Miss our doctor?
No, it's not.
Not him. Okay.
Robert Kennedy. Robert Kennedy Jr.
Thank you very much. Okay. All right. So he's the secretary for that. And part of the changes and stuff like that that he has made, you'll see how it trickles down to how it affects all of us, because I'm a senior citizen too. And then when they do the policy, then it comes down to the state. And the state then goes ahead, come up with rules and regulation. From the state, it goes to the hospitals in terms of rules of engagement. And you'll see some of the major rules that they use from CMS, so that you can see how it affects you directly. The reason why this matters is because we all go for doctor's visits. Somebody once asked me that, what do hospital administrators do? All they do is just get paid well. But what they do is not that important. I'm not going to mention names though. So I was mentioning to him, and you will see later on what hospital administrators do. I'm talking about senior executives, what they do and how it affects your life. But when you go for doctor's visits, depending on the kind of coverage you have, that's is going to affect how the doctors get paid. And most of the hospitals, they'll give you a paper to sign that if your insurance doesn't pay or if Medicare doesn't cover this, you are going to get the bill. And it doesn't take much for the bill to rack up, from the nodding of the heads. I think, some people, know about that too. Then pharmacy prescriptions. I'm going to present to you things that most people don't realize about pharmacies in terms of how they affect our lives, me included, and then hospital stays. It all depends on, per hospital stay, you may rack up about $10,000 a night. Imagine if you're there for a week. But depending on what kind of Medicare coverage you have, you can be rest easy that your pay, your cost is not going to be as expensive as it should be because it's covered. I will go over the different kind of Medicare coverages, the major ones. There are some minor ones that I don't want to cover because I don't want to confuse you, but I'll cover the major ones and what they do. And then talk about when we are mostly older, because I'm not as young as what I used to. I used to play soccer when I was in college. But now, what I used to get to in 2 steps, when I count 15, I just stop and let the ball roll. You see, so that, we are not as strong as we used to be when we were younger. And the capability that we have then, we may not have now. So all of this matters when you see how the policies affect us. So most people affected, I already mentioned that. Now, Part A, once you turn 65, you have to sign up for Part A Medicare. That one covers most, not everything. It covers most of your bills as an inpatient. Up to a certain, it used to be that we cover it completely, but now they have a copay that goes with it, depending on, when you sign up and things like that. If you have Part B, that is for outpatients. If you go to see your doctors, it will cover most of it. You see, all of this used to be covering everything before, but now you have a copay. And if depending on which one you have, some of them, when you get to a certain point, of your deduction, they pay the rest of it. And I'll mention that later on. Then we have C. The Part C is a combination of inpatient, outpatient, and drugs. The drug one is D, Part D, D for drugs. And then it depends on which insurance, because what Medicare does is that they know they can't handle everybody in the country. Because I think people on Medicare, we have close to about 68 million in the country. So what they do is that they find different insurances who is going to be like a representative for the federal government. And information that they have automatically goes into your Medicare, into your Social Security. So when I, turned 65 and I went ahead, I got my A and B. Later on, with discussion, with my family, I got a C I got a D, excuse me, for drugs. And for that, they have classification of drugs. And depending on the classification of the drug you have, there's some classification where they will only pay maybe about 70% of them. And there's some medication where they will pay everything. So depending on the prescription that I was getting, for example, last year summer, I was in the hospital. The day before, I was doing just fine. A friend of mine, a classmate, came to visit from Nigeria, and I went to pick him up from DC. Within a week, we traveled about 1,000 miles. We were having fun. We went to Glen Falls. Is that what it's called? Watkins Glen. So we were climbing. We climbed all the way up. So I was doing everything. He left a couple of weeks after that. I couldn't walk upstairs. I was badly out of breath. When I got upstairs, everything cleared. The next morning, I slept well, woke up. After Daniel and my wife went to work, I couldn't breathe. I was sweating. I had to call them. They take me to the ED. From ED, they took me to the ICU. Needless to say, I spent 3 days in the hospital. I had blood clot. For people who don't know, if you are not healthy or athletic and you get a blood clot, it can lead to a massive stroke that can kill somebody. It can lead to all kinds of damaged heart. Luckily, my heart was okay. I had some in my lung, and most of it started from my left knee. I didn't have any other symptom. They were asking, was your leg swollen? I said, no, I went to the gym the day before. So I was put on a medication, Eliquis, that I took since last September. I just got off of it this month when I went to see my doctor. No, last month, end of last month. Eliquis is in the class of medication that you have a high deduction for. Every time I pick it up, and before I reach my my threshold, a prescription for that costs $670. No. That is what I have to pay. Yes. That is not a matter of
Total
copay.
cost of the drug, you know?
Sorry?
You know what the total cost of that drug is if you had to pay for it outright?
Well, I paid for it outright. That's how much I have to cover.
How much, 600?
Was it supposed?
Yes.
600 plus.
You have the advantage.
But you see, and that's what I'm talking about. Most people think I have but still, the drug, you have a threshold because if you have the advantage, that he's talking about, yes, you need, what I have instead of the C, I have a G, right? Yes, I have a G plus, which covers any copay if I'm in a hospital or a doctor or anything. Because of that threshold, I have to pay for a couple of refill of the drug.
If I could just say, number of us have been teachers with the state university.
Mm.
We have the Empire Plan. And so these Humanas and everything else are coming at us with the advantage. Do not get rid of your Empire Plan. Do not get rid of your Empire Plan. So my Eliquest that you pay $600 for,
Mhm.
will pay us $60 every 90 days. $60 because Empire covers it.
But now that I've paid for that a couple of times, I don't have to pay for it anymore.
Wow. good.
Oh, that's good.
You see, because,
For that year,
sorry?
for that period of
For
time,
that
1 year. Right?
Yes. I mean, it took a consultant, Leah and I, figuring this out. took almost 6 weeks to find out which one should we get. And this is somebody who work in the hospital. I have an idea what it is. So you can imagine somebody who doesn't have any idea.
Petty.
Too complex. It's way too complex and hard for the average person.
Yes, yes.
Yeah, make sure you use that as a medical deduction on your taxes.
Mhm.
Yeah.
Oh, really?
Okay.
No, no. So the question I was posing before, that what do hospital administrators do? You see this hospital, these are all the people that they need to make happy. The boards of governors, you see, non-clinical physicians, non-local patients, like somebody who is visiting here and is sick and end up in the hospital. We have medical residents come from different schools of medicine. We have students and residents. These people are doing what you call, what do you call it after residency? No, not internship. Fellowship. Did somebody make fellowship? Thank you. Fellowship. These are the residents. And then we have physicians. Most people don't realize that almost 90% of the physicians you see in the hospital are hospital employees. There was a shift from about 20 years ago. And the reason the shift was that a lot of physicians will have an agreement with the lab, outside lab, and have an agreement with outside radiology, facility. And it was like turning the air conditioner on and opening the windows. So all of this money was going out. So what the hospitals did across the country, at least I'll say most of them, was to bring the physicians in, they pay them a salary, and applause for them. Why the physicians didn't kick too much was that they pay their insurances. Yeah, malpractice insurance. So that now they have to use the hospital's pathology department. They have to use the hospital's radiological, departments. If somebody needs to have a cancer treatment, now unless it's cancer that you don't treat locally, they have to use the hospitals. So we have, and then we have payers, third-party payers. When you have an insurance, usually that will be the first party is you. Your second party will be your insurance. But then at times you have a third party payer because you have an HMO or something like that. And part of HMO is that they will tell you where you can go for treatment and where you cannot go. So now with the kind of insurance that the coverage that I have, I can go anywhere, in the US to get treatment. If we're on vacation in the Philippines and I feel sick, we can always fly to Guam, which is about 2-3 hours from Manila. About 2-3 hours from Manila to go get care there because it's part of the US. So it does that. And then local paying patients, which is us. Then we have, the HMO, like I was talking about, organized management care. And then you have administrative services, people that work for you in, managers, directors, administrators. And then you have professional employees, pharmacists, nurses, and you know what I'm talking about. Then you have the indigent patients. Like I told you before, we do not in a hospital differentiate between somebody who can pay and somebody who cannot pay. Most of the hospitals who are for profit, what I'm talking about major are the non-profit hospitals, non-profit. Because when you say non-profit, you still need to meet your goal of finance. Otherwise, you won't be able to pay everybody or have money to have a new ED or buy a new machine. But there are some that are strictly for profit, like HCA. The difference is that people with for-profit hospitals, it has happened in the past that people died with maybe about $80,000 bill and then passed away, and they put a lien on their probate. That we need to get paid first before the families. But then they got a very bad press. So they don't do it as much because it used to be about 10 years ago, the standard practice for each year. But now they just do it depending on, each individual. And then you have insurance company. The last job that I had, I was in charge of oncology programs for 3 hospitals. And I tell you, before we start treatment, at times we will get approval from insurance. They will approve it, give you a number that, well, this is your ID number for the approval. When the bill hits, they'll deny it. And they say, well, we need this information. And then you have to prove that you sent it or you send what they ask you, and they still deny it. Then usually you have to then talk to their medical director and schedule a meeting with him and the medical director of the oncology program. And then they have to talk, and then they go like, or write a letter and use NCCN guideline, which is the premier guideline in the world for the treatment of oncology. So in case you have any oncology patient questions about treatment, let me know. I still have free access to the report where they dictate what you should do depending on the diagnosis of a patient. So that if somebody is being sued, now, for example, if you follow those guidelines and somebody sues you for malpractice, you should be smiling. Because when you go to court and you show them that this is based on science and this is what we're supposed to do, they usually throw the case out. So it's the gold standard of care. Of course, you have states and local regulations. You may be doing everything right, and one patient is not happy for whatever reason. All they have to do is to call the state or call CMS. And within a week, they will show up unannounced. At times, let's say it's a nursing home, they may let you know that where we are going to be coming. But in hospitals, usually you just come in at 7 o'clock in the morning because we have a code overhead that we use for announcing when they're around. That's it. And then they ask for the chart and audit the chart to make sure that what the patient complained about is true or not true. And with that, if it's based on charges, it's the IOG that come to audit you. We had one when I was an administrator in Vermont. They stayed with us for 6 weeks, going through all the patients for 10 years. Some before I even got to the place. So they found one particular code that we were using. And they said, well, you are using this incorrectly. We told them the reason why we're using it. But if they come, they will find something wrong. Technically, we didn't do anything wrong. But they still say, okay, we'll find you 30,000. And then every 3 months, you need to send us all of these charges and the medical record number so that we can audit you remotely. Then they change it to 6 months. Then 1 year. After about 2 years, gone. Because they can't go back home and say, we spent 6 weeks and we couldn't find anything. So that's why they stayed that long. But if they find that you intentionally are charging for something that you're not, I have known hospitals that have been charged $11 million. And it's not like, well, can I pay it 100,000, every 6 months? When you owe, it's like IRS. You owe money to the government, they're even worse than IRS. They will get that money. And some hospitals have closed because of that. And of course, you have professional associates. For example, If you're a doctor, let's say somebody is from UHS and you want right to see patients at Lord's, they cannot say no as long as you meet all of their medical staff guidelines. Even though you are not one of their physicians, but they still have to give you access there. So if you have a patient that is admitted there, they can always come there to see you and round on you. And the same thing goes with UHS. If somebody from Lord's wanted to, as a matter of fact, a friend of mine from Nigeria, he's a surgeon. He's a member of the staff at UHS. He became the chief of surgery at Lord's about 7 years ago. Because to become a chief, there's some guidelines that govern that too. You can't just be a general surgeon and be able to do that. You have to specialize in things like that.
And the doctors charge more because they're so-called not participating? Not participating, so
No participating in what?
a doctor from Lord's wants to go to UHS and see a patient.
Yes.
UHS charge more money because he's not a they're not a participating doctor with UHS.
You know, I don't know. I think one thing though, if it's a Medicare patient, you can charge all you want.
Yeah, but
The government
Insurance
can
company
pay
block
what they
that.
can.
say you have to be participating. Participating.
Yeah. Actually, I don't know. That's the best answer I can give. Oh, somebody is raising the hand remotely.
Don't see anybody.
Oh, I see a yellow hand up here. Okay. All right. So what I just gave you is just the background. He thinks is that, or there's some what you call KPIs, key performance indicators, that governs what CMS does. They are supposed to, by law, governs them. Okay. That doesn't mean that it always happens. Interestingly enough, this is not a political presentation, and I don't want you to take it from there, because it's not just the president we have now who have done things wrong. Starting from the second, what do you call it? For Obama, his second term, starting from his second term, things have been rolling, and now it's coming home to roost. So the key performance indicators that CMS has are four. Safety, patient experience, efficiency, and outcomes. They actively collect data for all the hospitals in the country. And if you go to Leapfrog, you can get some of the information there, and they publish it. If you want to know more about any hospital you want to go to, things like how many errors in surgery do they have, the delay, and then they evaluate the doctors, patient satisfaction, how do they talk to their patient? That's why you get questionnaires after you've been in the hospital. All of that information goes out to the federal government, not state, federal government. So that if they are noticing that people are unhappy in a hospital, they are going to show up. So you have that, and then patient experience are things I'm talking about. They look at physicians, they look at nurses, they look at nutrition services for inpatients. What else do they look for? The number of errors that you have. And in a hospital, if an error occurs and a patient dies, automatically it has to be, pushed up to CMS. Just like if you do it in the industry, somebody dies, you have to call OSHA. And in industry, if somebody dies, somebody is going to jail. It's just a matter of who do you want to squeal on. In a hospital, you may not necessarily go to jail, but if they come and find out that it's a physician error, they may ban that physician from participating in Medicare. And if they do that, that's a kiss of death. Because 30% of the patients 33% of the patients we have in hospital empirically are Medicare. 33%. Then they talk about efficiency and outcome. Just to give you some interesting data, in the top 10 industrialized countries in the world, the US is on the 10th position. Of the top richest countries in the world, 32 of them, US is number 7. Who knows the top 2?
New Zealand and Australia.
Nope.
Sweden.
Nope.
Nope.
Number 2. Who knows number 1? No. It will surprise you. It's Singapore.
Singapore.
Has anybody here been able to go to Singapore? Okay, 1, 2, and both of you. We have been to Singapore. If you have been to Singapore, you will know exactly why. It's a very clean country, very disciplined, 0 crime. 4 o'clock in the morning, 3 o'clock in the morning, you can walk anywhere, even in the alleys. Nobody's gonna touch you. You can get in an elevator without anybody, harassing you. You cannot chewing gum in Singapore. Remember the case of a young man from the US who was chewing gum and he spit it out, and they sentenced him to lashes of the cane, and it became a diplomatic issue. And US was saying that, well, we'll do this and that. They ended up caning that kid. I think it happened in the 80s. They ended up flogging that kid. Eventually, that kid, I think it's only about 13 years old. It doesn't make a difference. And the parents eventually have to leave Singapore. You cannot smoke on the street either. Or throw trash. Somebody does that, they're not gonna like what's gonna happen to them. If you go into the trains from Shanghai airport to go downtown Singapore, you will not see a single writing on the wall. But not everybody liked it because a cab driver was complaining about it. But I don't think he realized what Singapore looked like in 1959, in 1960, and what it looks like now. I'm just going to go through, before I address the KPIs, some of the things since January that have happened that may be affecting your healthcare and my healthcare. Rising in premiums. What happened was that, remember the big bill that was done, and they went ahead and took away the subsidies in ACA, aka Obamacare. That led to 25 million people being uninsured. So since the insurance company can't make money from ACA, they still have to make money because they have to pay their investors. So the other end is where they go to make sure that they increase the premium for the people who are insured with them. Oh, see, 20 million people were eliminated. How many did I say before? 20 million people were eliminated because of the subsidies. And this doesn't include, because part of the rule of that law was that before, if you are illegally in this country and you go to the ED, they need to treat you. Now they're saying that no, you can't do that. But some hospitals still do it anyway. But the government is not going to pay for it. And some states are not going to, especially in the southern part of the US, they are not going to pay for you, for somebody who is illegally in this country who has medical issues to go. So this is just the people with AC, with Obamacare, that because of the subsidy that they banned, they had to leave it. So we have a declining enrollment of about $12 million people just because of that. And the lawful immigrants that were denied coverage, when I say lawfully immigrants, somebody who has a date to come before a judge, they haven't denied it yet, and they probably may approve it. But the fact that the judge hasn't said yes, even though you have a court date, and usually in the past, you are covered when you have that. About 300,000 people who fall into that category now, you are shaped as if you come through the border yesterday. Also, some of the initiatives that they did in terms of renewed focus on hospital and insurance transparency, the rule says that every hospital, this was made as part of the Obamacare rule, but it wasn't enforced until about 2 years ago. And that's the timetable that they have there. It says that every hospital on their website is supposed to post how much everything costs them, so that you can go look at how much does an x-ray cost here versus how much it costs in hospital B and how much it costs in hospital C, and choose which one you want to go to. But unfortunately, we've had a modest gain on that because most people don't know, and most hospitals hide it somewhere where you have to really dig to find it. But I have good news for you. If you're going in for any surgery or any invasive care, if you call the hospital that you are going to, by law, they need to give you how much your entire cost is going to be. Because in oncology, we do that for patients. When you start care, we'll tell you how much treatment you're going to get, because that's what we give to the insurance to get approval. If you don't get approval and you start treating a patient and you say, oh, it's an emergency, even if the cost is $200,000, you will not get paid a dime. So we always make sure that we get approval. And I told you earlier on how you get the approval and they still want to renege on it. Now, also, we need improvement on the Part B, premium growth, because I told you why it's growing, but we need it to come back down, and then to have a more competitive Part G premium, which is a little bit higher now, and reduction in out-of-pocket payment. All of those were privileges that came with Medicare before, but with different laws, they have some conservatives in Congress and Senate that are against that, so that every law that they make, they chip away on that, and the people are the people who end up getting the shaft. Another initiative that was done has to do with the affordability program, to make sure that the intermediaries, aka pharmacy benefit managers, that they remove them from the equation. And I'll show you why in a second. Because if you can remove them, your premiums will be lower. happier with what you have. Well, throughout last year, and they ended up with a great health plan. But the impact is far from being realized. And I'll show you the reason why that is almost impossible to do. On paper, yes, it's good. As a election slogan and stuff, it's very good, but it's very hard to do. And the reason it's very hard to implement has to do with the amount of money that goes to all politicians and where they are coming from. The next slide is going to show you how that works. Okay. This, if nothing that I've talked about, please pay attention to this. What happens, this is from this infogram is from Wall Street Journal. You'll get a copy, Rick. You'll get a copy of this. What happened is that they said, okay, if a drug is listed at $300, how does it affect everybody that have their finger in the pot? Number one, because the patient is insured, they may have to pay, let's say, $35. Okay? For paying that $35, insurance may charge them $16. You follow me so far? Okay. Wholesaler, $3. Remember, we're talking about $300, what everybody, contributing to it and how they take it. Then the drug makers, they will say because of the R&D, even though some of the R&D is given to, the money for the R&D may be given to them by the government, for example, during COVID or other ones, still, they are the ones who are going to file, make the money from it. You remember when we had an economic downturn just before President Obama came to office? Do you remember what he did? President Obama.
The Affordable Care Act thing?
No, before that. I'm talking about the housing bubble that busted before he came in. Yes. The first thing that he did was to negotiate with them that we will bail you out. But for that, we are going to take this percentage of your company. So there's no handout. And the government erecting a lot of money from doing that. Usually when that happens, the government will just bail them out and don't put any string to it. And they continue, business as usual. So from GM, say, okay, you get this number of $1 billion, but for that, you are going to pay your money back, and we also own maybe 15% of your business. Eventually, by the time he left office, he divested that, get all of that money, and put it in the government coffer. That is the ideal way to do business and to run a country. But the drug makers now, what they will do, and they've done it with other Democratic presidents in the past. So it's not just Republicans. So they say because of R&D that they deserve $137. Now, you see this guy here, all he's doing is making sure that, well, when somebody develops a drug and somebody wants to buy the drug, they get that, okay, we'll sell it to more people if you give us a rebate. And then let's say the drug is $20, you can give a rebate for $5 or $7. So that's the only thing this person does.
What are you talking about there?
That's the pharmacy benefit manager.
The red circle on top.
The red circle. But do you know who owns those companies?
Drug companies?
Exactly, the pharmaceutical companies. So in essence, you see, you add the 102 plus 16. That is how much goes to them. And since these people make sure, and that's CVS, Optum, Unit Healthcare Optum, and Scripps, they control 80% of intermediary. So when the politicians say, oh, we want to change the rule and remove the middleman so that you are dealing with the pharmacy directly, which is going to make it just like you are getting a generic. Because that's a reason why generic and regular usually about doing the same thing.
The brand name stuff when you were saying regular.
Yes, brand name, if you want to call it like that. They do about the same thing, but the prices are very different. So they make sure that they give money to the politicians. And they did a research and found out that politicians spend 80% of their time raising money for the next election. And it starts the week after they're elected.
Mm-hmm.
So that is the area there. Now, what can we do about this? As church leadership, we have a responsibility to you. Part of it is what I'm doing here today, to give you information. Part of it is to make sure that if you have any issues with Medicare or with your insurance, let us know. I can do research. I am not your advisor and I don't get paid and I don't want to be paid. But I can do research based on my knowledge to give to you to help guide you on what you want to do. Also, for lawmakers, it's important that we have advocacy. People, need to understand that you cannot vote for a politician just because of a party, or just because of one issue. You need to look at it in a very global way. If this politician, if what they are trying to do, let's say you don't like what Schumer is trying to do because the policy is put in there, is going to affect your health. And I tell you, health is the most expensive thing for anybody who is a senior citizen. We need to start voting for people who is focused on what we want to do and our health. If you need more information, you can read, usually before a big election, AARP usually give an idea where each politician stands. Both my wife and I are members, and I read that religiously before deciding on who I vote with. Yes, sir.
The other one that puts out really good information, I believe, is the League of Women Voters. They have much more information I've ever seen AARP do. They're fantastic on coverage, or they used to be.
Okay. But like I said, any of this information that are published, take it with a grain of salt, read it, do your own research. If you have questions, ask, people where they get their information from, and they'll do it. Yes, sir.
Eddie, thank you. Your bullet points here are a good starting point for anyone to make decisions about anything.
Yes.
Thank you.
But you see, most people now, they care so much about their healthcare. They don't have to care about grandchildren. They don't have to care about, it's healthcare and how much they spend for utilities and grocery and for gas. Yes, sir.
I think another important forum to build upon the foundation that you made here about cost for us that are plus 64 would be to do a forum on trust, on legal trusts.
I'm going to get there. Stop reading my mind. That's an invasion of privacy.
Reading his mind is an invasion of privacy and
Yes.
HIPAA. Okay.
So, and it's not just only presidential, choosing your state senator, choosing your state's congressman, choosing your national congressman and senators. These are all important ones. Choosing your mayor is very important also, so that, and even city councils, because if you have city council members who are not inclined towards what is good for the general people, because anybody that votes usually will welcome money as long as it's not a shady money. And you don't get money from somebody and they're not, wink, wink, if they need something when you are, because then you can't go back to that well to draw water next time. So, but it's very important that we make sure that we hold our politicians' feet to the fire. All right. Individual responsibilities. Apart from advocacy, there's a movie that I would suggest for you to watch. My wife called my attention to it, and we sat down, how many weeks ago? 3 weeks? About 3 weeks.
How long is the movie?
About an hour and a half. It's called Bad Guardian. It's in line with what Jamie was talking about. Because you will be amazed if you don't put your life in order. I know that you have a will, but there's some other document that is important that you have. Well, you just need to watch that movie because I don't want to tell you what happened in it. Make sure that you put your legal document in place. Vis-a-vis durable power of attorney, healthcare proxy. So if something happens to you, who makes the decision for you? And oftentimes when this is not taken care of, it can lead to a whole family being splintered. Because then emotion gets in the way of it. For example, when my father was alive, because of the difference time of 6 hours from here to Nigeria, Daniel was just, this time I'm talking about this bracket of time, Daniel was an infant. But my dad will call, and it will be about 3 o'clock in the morning. And they say something back in Nigeria that if you have elderly in the home, elderly family members, always answer your phone, irrespective of time. You can't go like somebody, disturbing you. And I will pick up the phone, get out of the bedroom so that Leah can sleep and Daniel can sleep, and go talk to him. My immediate big sister, she was a pharmacist in Maryland. If they call after 10 o'clock, she doesn't pick up. About a week before my father died, I spoke to him. I was telling him that, wow, your voice is kind of weak. But, he put a bravado on that. Me, no, everything is fine. But I know not everything was fine, that he was sliding. So that when I heard that he passed away, I missed him very much because he was one of my best friends. But my sister took it very hard. That, I wish I'd pick up the phone when he called. You see, and this kind of things gnaw people inside, So make sure that you have the proxy and the living will so that there won't be any emotional burden if we're sick and stuff like that. When you make any of these documents, make sure that you choose the right person. Some of the things that you want to watch out for people not to choose. Don't choose somebody who is in debt or is very poor with money management, or somebody who has control issue. Because if you watch that movie, you'll see some of this, workouts there. And you want to choose someone, don't choose somebody who's going to benefit much from this part. One of the things you can do is to use more than one person. So that if you use a lawyer, it's even better, because then the lawyer is involved, and if they need to execute that, and the lawyer has had considerable conversation with you when you are doing this, they can go like, no, that's not what she said. See the letter that, your uncle left, your dad left, or your mother left before they got too sick. So that's building the oversight in as a third party, and then make sure that after you do this thing, if possible and you can afford it. I called Broome Center for the Ages. They don't have this service. And then I checked to see on the average, I'm talking about what I'm going to talk about now, about how much it costs on the average here. And it's kind of expensive. It's almost $1,000. But if you have a trust overrules everything in terms of if somebody passes away, they will not have to go to probate. You do the trust while you're alive and you're still functioning just fine. You can do a regular trust or revocable trust. So, but it's very important to do that. They do have the earlier ones that I mentioned, durable power of attorney, healthcare proxy, and living will. They have two. They do have them, New York Law Association or whatever they call them. They do have them, and they are relatively inexpensive, where you get a format to use. If you're interested, let me know after this presentation. So that is what I have. If I get a chance, because I know we have a very full year, but if somebody drops out, please let me know. I'll be more than glad to bring a physician in who's going to talk to you about things from their perspective in terms of what causes, why do we do lab tests if we did one last week or we did one last month? Do you need, referral to go to a specialist, or you just go there? If you do and you get a healthcare and you're supposed to get referral, you may end up having to, to be responsible for that cost. I have a whole bunch of sources here. And, just like I said, I'll send it to John. If you click them with any of this information, you can read more about it if you like to read stuff. That is what I have. Does anybody have any other questions? Yes, sir. And I'll come to you, Jamie. Go ahead.
Then go for it.
Penny,
Yes.
so the trust is dead nuts on for us older.
Say that again.
For having a trust is dead nuts on as far as us over 60.
That is correct.
The other thing you want, I think it's a 5-year look back now. 5-year look back on your property, so that you have to, mine's included in the trust, so the house can't go to the cost of the nursing home. Say if I go in a nursing home,
That is true.
5-year look back.
Yes.
What do you mean by that? By a
Well,
five-year
you gotta
look back?
have your,
It's not factored in.
say you have a son or a daughter. You wanna make sure you have a, in the trust agreement that your house is gonna be their property, either in the revocable or irrevocable trust. So that after 5 years, you go in a nursing home, Medicare is gonna cover some of it, but the rest of it's gonna be covered by your estate in a trust, irrevocable or revocable trust.
So what you're saying, you have to transfer the property 5
5
years
years.
prior to entrance,
Correct,
prior to death or entrance in a nursing
correct,
home.
correct.
Yes.
And it can't be touched. Then your kids are gonna get it, or whoever's in your trust is gonna get it.
Now, if you have a
Some states, like Connecticut, have some very specific rules.
Well, I'm talking New York State.
Yeah.
Our trust is New York State, so.
Yeah.
If you got property in another state, you probably gotta talk to an attorney from that state.
Yeah, I would say so.
yes. remember I mentioned there are two kinds of trusts. The one that Jamie just talked about are the irrevocable trust. There's another one that is called revocable trust. So for example, maybe you have a single, daughter or son, and you decide to use them, to give everything to them. And then either one of them marry a jerk. And it does happen, you can revoke it. So
So you're recommending to do a revocable trust.
I'm not a lawyer. I'm not a lawyer, but if I'm going to do one, I'm going to do
That's the
one that's revocable.
right.
Now,
that's the risk.
suppose you have a revocable trust and then you realize that, hey, there's no idiots in the pipeline. Can you convert a revocable to an irrevocable?
That is correct. See, your lawyer is going to be you cannot do trust at home. It is very complicated, and if you don't cross the T's and dot the I's, it will become, illegal or, non-enforceable. So you need to use a lawyer who is an officer of the court.
Irrevocable is a risk.
It is.
Exactly what,
It is.
it's a risk.
Yeah.
So you just,
With everything, life is a risk. So you choose which one you want to go. Any other questions? Yes, sir.
I had two questions. One was, did you discuss, I had to go eat. You're talking about indigent people and stuff. People are on Medicaid. Did you cover the difference between New York Medicaid and federal Medicaid?
Yeah, together.
Well, it used to be they were apart unless they remerged, because what somebody I know that happened, they had Medicaid from New York State.
Mhm.
They're down to Georgia visiting relatives, thinking they had Medicare coverage, or excuse me, Medicaid coverage.
Yes,
Georgia did not recognize New York State's.
that is correct.
And they had to pay the whole bill, so.
That is correct.
And-
What happens is that it's the state that you apply to,
Hmm.
and the state who is going to pay, and then they turn around and act it up to the federal government for part of it to be paid. Because, for example, when I was in Illinois, if you apply for Medicaid, it takes 6 months, even with everything being in order. In New York, it's a lot faster. But in terms of payment, that is the way it goes. Second question?
Go ahead.
Yes, sir.
so I go into Elizabeth Church Manor. And let's say I have $100,000 in my estate.
Yes.
Elizabeth Church Manor can say, okay, Medicare is going to pay for part of it, right? And then I'm going to have to use that $100,000 to pay out of pocket every month to stay there. When the $100,000 is spent, can they throw you out of Elizabeth Church Manor?
I think you need to talk to the controller. Leah. If somebody's, savings runs out, can they throw them out of the nursing home?
No, you can't. Oh, okay.
Well, thank you very much for coming.